So at this ESMO 2017 meeting, I think the most interesting and impactful data towards the field is going to be in the setting of adjuvant therapy after surgery. And here at the meeting, we're going to have 3 presentations, which are all a big deal, surrounding the BRIM-8 trial of vemurafenib, BRAF inhibitor versus placebo, the Combi-AD study of BRAF-MEK, dabrafenib, trametinib versus placebos, and then the Checkmate 238 nivolumab versus ipilimumab placebos. And all of these data sets are reading out as positive, meaning improvement at least in relapse-free survival. Longer-term follow-up in terms of overall survival is less mature at this point, but all other prior therapies in the adjuvant setting for melanoma have been approved on relapse-free survival. So now we're going to have 3 regimens really that are moving into the space very quickly. So we think about just a few years ago, it was high-dose interferon, which was not an option that people liked, and then we had ipilimumab come in. I think those are even rapidly, both of those are now going to become obsolete. We're going to move into a future where the question is, how are you going to choose for patients whether or not you pursue BRAF-directed therapy or immunotherapy with anti-PD-1? And I think the answer is we don't really know yet. And this is a space that needs a lot of work in terms of biomarker detailing. It's not clear what the overlap is between, are all the BRAF mutant patients going to have the same benefit from immunotherapy? Are they different patients? So on and so forth. So I think there's a lot still to learn. So these will be the first presentations. Presumably these will all lead to regulatory approval of these different approaches, and how that is going to play in terms of which one gets chosen for an individual patient, I think is yet still to be defined.